Hello and welcome to part 2 of 2 presentations on the wrist. So in this presentation we'll start with a look at the carpus, Gilula's arcs and the zone of Johnson, and then we'll look at scaphoid, triquetral and hamate fractures, carpal bone dislocations and avascular necrosis of the lunate, the classic Kienböck disease, and then we'll wrap up with a look at the physeal scar, which is very important because this is often misdiagnosed as a fracture, so it's most important that we get to the end of the presentation. Okay, hope you enjoy.
The carpus are vulnerable to dislocation as a result of major trauma, and so it is important to evaluate alignment. Now, the normal carpal joint space is 1 to 2 millimeters, and that's exactly the same for the carpo-metacarpal joint. And in the same way, when we're evaluating the base of the 4th and 5th metacarpals for dislocation, what we're looking for is the ability to see a clear joint space without any overlap of the adjacent bones. So we use Gilula's arcs to help us to evaluate carpal alignment. So the first line we draw along the proximal articular surface of the proximal carpal row. So therefore you're drawing a line along the proximal articular surface of the scaphoid, the lunate and the triquetral. Your second arc is drawn along the distal articular surface of the proximal row. So you're drawing a line along the distal articular surface of the scaphoid, the lunate and the triquetral. And finally, your third arc is drawn along the proximal articular surface of the distal row, so you're coming along the capitate and the hamate. And so it's important that you can see a clear joint space between these rows. And if you can't see a joint space and if you have overlapping bony structures, then you need to be really suspicious of a carpal dislocation. The zone of Johnson is also referred to as the zone of vulnerability, and it's really helpful to understand that most fracture dislocations will fall within this zone. And what happens is that you're more likely to sustain fractures within the radial started process, the scaphoid, the capitate, the hamate, the triquetral and the ulnar started process. Now, as the zone progresses from the radial aspect towards the ulnar aspect, the severity of the injury increases, but the frequency decreases. So, for example, fractures to the radial started process and scaphoid and to the ulnar started process are relatively frequent, but their injury is less significant than when you start to sustain injuries to your capitate and your hamate, which are much more significant injuries but much less frequently occur. The scaphoid is the most commonly fractured carpal bone, and it's important that we get full visualization of it. When we think of the carpals, the capitate in particular is kind of like a maypole. So when you position your patient into ulnar deviation, what happens is that the carpals rotate anti-clockwise around the capitate. And because the patient is then put into ulnar deviation, what this does is that it allows for full visualization of the scaphoid because it's been opened up as the carpals rotate anti-clockwise around the capitate. Conversely, if you position the patient into radial deviation, what happens is that the carpals then rotate clockwise around the capitate, and this results in foreshortening to the scaphoid. And we can see here this circular density where the scaphoid is. This is referred to as the signet ring sign, and this doesn't actually mean that the scaphoid is fractured. What it means is that the scaphoid is completely foreshortened, and therefore it becomes really difficult to evaluate this bone for any fractures. And so therefore it's really important that you always put your patient into ulnar deviation if there's any question of any injury to the scaphoid. Most scaphoids have a blood supply that enters distal to the base of the scaphoid. So this means that all fractures to the proximal pole will result in either delayed or non-union, and they have a really high risk for avascular necrosis. So avascular necrosis is when you have an increase in density, i.e. sclerosis of the fracture fragment. But most importantly, you must have flattening and fragmentation. So if you only have an increase in density, this doesn't necessarily mean that the patient will develop avascular necrosis, and I'll explain a little bit more about that in a moment. So fractures that occur to the waist of the scaphoids, and this is the most common site and occurs in about 70% of fractures. If that fracture to the waist of the scaphoid is proximal to the blood supply, then you're going to have delayed or non-union with a high risk of avascular necrosis. Now, if the fracture is distal to the blood supply, then there's going to be no risk of avascular necrosis because the blood supply isn't interrupted. So all patients that sustain fractures through the distal pole, of which is only seen about 20% of patients, they don't have any risk of avascular necrosis because the blood supply is not interrupted. And all fractures that occur through the proximal pole will all result in delayed or non-union and have a really high risk of avascular necrosis. Frequently, when you get a scaphoid fracture, within a couple of weeks, what happens is you get so much resorption of the fracture site, it will look actually quite cystic, i.e. so it has quite a lytic appearance. You also get an increase in density to the proximal fragment, and there's two reasons for this. So the first is you get rarefaction of the surrounding bones and the distal fragment. And that's basically because there's a really good blood supply. So essentially what happens is that the bone is undergoing a lot of resorption. Now the second reason is that what's happening to the proximal fragment is that you're getting more bone being laid down than has been resorbed. And so that is creating an increase in density. And it's for this very specific reason why if you have an increase in density of the proximal pole, this doesn't necessarily mean that there's avascular necrosis. And if you were to describe it as avascular necrosis, you must have flattening and fragmentation as well as sclerosis. So no flattening and no fragmentation, you can't call it avascular necrosis. Okay, here we have a scaphoid fracture, but before we concentrate on the fracture, let's have a quick look at the distal aspect of the radial cortex. And you can see there's a little notch here, and this, or lump I should say, and this lump is normal and sometimes can be misconstrued as a fracture, so it's important to recognise the normal appearances of this location. It's important to, when you look for a scaphoid fracture, to identify the fracture particularly in the fracture of the medial cortex. If you see a break in the medial cortex, you can be really quite confident that this is a scaphoid fracture. In this instant, we can actually see a very lucent line, a very transverse fracture with breaks in both the lateral and the medial cortex, or the radial and the ulnar cortex. Unfortunately, in this instance, it's undisplaced, so it has a better prognosis, but it does involve the proximal pole, so there will result in delayed or non-union. Most hospital policy are to do 4 views for scaphoids. Scaphoids are notorious for the fractures not being visualised on first presentation, which is why patients are quite often casted and then asked to come back in 10 to 14 days if they're still asymptomatic. And that's when they have tenderness to their anatomical snuff box. Now most hospitals do 4 views, so it's the PA in ulnar deviation. That's really important to put them into ulnar deviation. a PA oblique, although some trusts do AP oblique, a zeta view or banana view, which is when you angulate the beam by 30 degrees and you put the patient into ulnar deviation, so you elongate the scaphoid to have better visualization of the entire scaphoid, and also lateral. Now, we tend to be really bad with laterals at evaluating for scaphoids, and I think it's probably because a lot of people aren't very confident in identifying where the scaphoid is. So when we look here, we can see we've got the distal pole of the scaphoid, and we come down and around, and we can see the entire scaphoid on the lateral view. And we can actually clearly see a fracture going through the proximal pole on the lateral view, and that's why it's really important to always evaluate your lateral view as well as the other three views for a scaphoid fracture, because you may be able to identify it on the lateral. So what is it? It's a fracture where the proximal pole of the scaphoid, how minimally displaced. We know it's minimally displaced because the cortices are in alignment, there's no growth step, and so therefore it's only minimally displaced. Scapholunate disassociation is when there's been a rupture to the scapholunate ligament. So if you remember, the normal joint space for the carpals is 2 millimeters. So anything more than 4 millimeters becomes positive for scapholunate disassociation. It's possible to reduce the appearance of scapholunate disassociation if you put your patient into radial deviation. So remember, with radial deviation, your carpals move anti-clockwise around the capitate, and therefore it results in foreshortening of the scaphoid and reduction of the scapholunate joint. Conversely, if you want to adequately demonstrate scapholunate disassociation, you put the patient into ulnar deviation, and this will elongate the scaphoid, and it will highlight if there has been disruption to the scapholunate joint with diastasis. Now, this sign is sometimes referred to as the Madonna sign, after the singer who has a gap between her two front teeth. So this gap here is referred to as the Madonna sign. So what is it? It's scapholunate disassociation, where the scapholunate joint, and how is diastasis. After the scaphoid, the triquetral is the second most common carpal bone to be fractured. Now, generally speaking, you tend to get a fracture to the dorsal cortex of the triquetral, but occasionally you do get a fracture through the body. Now, it can be particularly difficult to appreciate the triquetral fracture on your PA view because of the overlapping physeal, but I do suggest that you do pay attention to this location on the PA view to see if you can see the fracture site. But most commonly, what we're looking for is an avulsion fracture, which is seen in the soft tissues just dorsal to the lunate. And in the context of PAM 3006, you can describe this as a triquetral fracture. If you also look carefully, sometimes the soft tissue swelling will also help to guide you towards making the positive diagnosis of a triquetral fracture. So what is it? It's a fracture where it's the triquetral. How? It's only slightly avulsed because it's still quite close to the adjacent cortex. The most common type of hamate fracture usually occurs as some kind of scrapper's fracture, where rather than fracturing the base of the fifth metacarpal, it results in a fracture through the medial cortex of the hamate. Sometimes you could have a fracture dislocation, so you may get a dislocation of, say, the fourth and the fifth metacarpals and associated fracture of the hamate. It's important to check all round the hamate to make sure that you don't miss any small fracture sites. The hook of the hamate is demonstrated as a cortical ring. Occasionally we can sustain a fracture through the hook of the hamate, and it's usually by golfers who accidentally hit the ground rather than ball, and the force drives up and breaks fractures off the hook of the hamate. So what is it? It's a fracture where it's the hamate and how it's slightly displaced. You can see there's quite a large gap between the fracture site and the adjacent bone, so therefore we would refer to it as slightly displaced. In order to assess for carpal alignment, it can sometimes be helpful to think of the capitate as an apple, our lunate as a teacup, and our radius as a saucer. And so the head of our capitate, the apple, sits within our lunate, and that lunate sits within the distal radial articular surface. And we want to make sure that we can draw a straight line through them so that we can be sure that the capitate, lunate and distal radius are all neatly stacked up and there's no dislocation. A lunate dislocation is when the lunate is dislocated out of the radius. It is nearly always dislocated volarly. Let's have a look at this. So we can quite clearly see our capitate here, but it's not sitting within the lunate, but our capitate has sunk down and is still in alignment with our distal radial articular surface. So although the capitate and the distal radius are in alignment, the lunate has tilted up and out, indicating that it is dislocated. Okay, let's have a look at this PA wrist. Do you remember Gilula's lines? Let's have a look. The first line was the proximal cortex of the hamate and the capitate, and then the next line was the distal cortex of the scaphoid, the lunate and the triquetral. And we can see straight away that our capitate has sunk down and that the lunate now has a triangular configuration. So we know that this row has been disrupted. If you look at our third line, affecting the proximal cortex of the scaphoid, the lunate and the triquetral, that's all still in alignment. So the area of injury has occurred in the mid-carpal region of between the capitate and the lunate. Be careful, sometimes the triangular configuration of the lunate is due to poor positioning, but other signs such as the inaccurate Gilula's lines indicate that there's an underlying abnormality. Now remember zone of Johnson. So we look carefully along the radial styloid process, through the scaphoid, to the capitate, down through the hamate, out through the triquetral, and we can see now that we've got an associated avulsion fracture of the ulnar styloid process. So what is it? It's a fracture dislocation where it's the lunate and ulnar styloid process. And how? Well, it's a volar dislocation of the lunate and it's an undisplaced fracture of the ulnar styloid process. A perilunate dislocation is the other carpal dislocation. So let's have a look at this more closely. We can identify our capitate here. And here, the head of the capitate, which represents the apple, does not articulate with the lunate, or the teacup, I should say. So here is our lunate, which represents the teacup, and the head of the capitate, or apple, does not sit within that teacup. The lunate, however, is still articulating with the distal radial articular surface, indicating that the alignment between the teacup, i.e. the lunate, and the saucer of the distal radius has been preserved. Now let's draw a line through the middle of the capitate, and we can quite clearly see that that line as we come out does not bisect either the lunate or the radius, indicating that there is a perilunate dislocation. Most perilunate dislocations result with the capitate being dislocated dorsal in relation to the lunate rather than volar. It can dislocate volar, but these are pretty rare. The other thing to be aware of with a perilunate dislocation is that occasionally the capitate may rest on the dorsal cortex of the lunate, and what happens is that the force of the capitate sitting on the dorsal cortex of the lunate will cause the lunate to tilt volarly, and so it's important that you recognise that this is a perilunate dislocation and not a lunate dislocation. And the way to confirm that it is just a tilted lunate rather than a dislocated lunate is to use that line, draw it down through the capitate, and you will then quite clearly see that it doesn't bisect the lunate or the radius, indicating that it's a perilunate dislocation and not a lunate dislocation. There are 8 carpal bones. Let's count them. So we have the trapezium, the trapezoid, the capitate, the hamate, the pisiform, the triquetral, the lunate, and then suddenly we have one extra bone. So this actually is a scaphoid with a fracture through it with a significant displacement. So it's important to always count your carpal bones because you can overlook a significant injury by assuming that it's just an extra carpal bone. If we think back to our zone of Johnson or zone of vulnerability, remember at the apex of the zone of vulnerability, this is where the frequency of the injury is quite low, but the severity of the injury is very high. So if you're looking at a mid-carpal injury, it's frequently associated with other fractures. And in this case, we have a scaphoid fracture. So when we describe a perilunate dislocation, we always describe the direction of the dislocation first. So in this instance, and to be honest, in majority of perilunate dislocations, it's dorsal. We then describe the fracture. So in this case, we have a scaphoid, and then you describe the dislocation, which is perilunate. Now, should, for example, you have a capitate fracture and a scaphoid fracture, how you would describe it would be dorsal, because that's the direction of the dislocation, and then you would say it's scaphoid, capitate. So you use the word trans before the fracture, the bone that has been fractured, and then you call it a perilunate dislocation. Let's just have a quick look at Gilula's arcs so we can see, we can appreciate the mid-carpal injury. So if we come along the proximal articular surface of the distal row, so we come down the hamate, along the capitate, and then we go along the distal articular surface of the triquetral, and then we go along the lunate, and then of course you've got that lumpy bumpy of the scaphoid. But we can see how the capitate projects more proximal over the lunate and scaphoid, indicating that we have a mid-carpal injury. Now if you look at the proximal row, if you look at the proximal articular surface of the triquetral and the lunate, and then of course it's lumpy bumpy with the scaphoid, we can see how the lunate, although slightly displaced medially, it is actually in normal articulation with the radius, and it doesn't have a triangular configuration, and so therefore the PA is leading us to recognise that the lunate is in a more normal articulation, and it's the capitate that's in the abnormal position. So what is it? It's a fracture dislocation where it's scaphoid perilunate. how it's dorsal for the dislocation and severe displacement for the fracture. Kienböck's disease is not actually a disease per se, it's a form of avascular necrosis. Now, avascular necrosis within bone, you tend to get this increased sclerosis and flattening and fragmentation. So it's the same sort of appearance that you get in the hip for Perthes as you get over the second metatarsal or third metatarsal head for Friedberg's infraction. The most common cause, though, is that a very high percentage of patients, about 70% of them, have a negative ulnar variance. Ulnar variance refers to the relationship of the ulnar to the distal radial articular surface. So if your distal ulnar is in alignment within the distal radius, you have a neutral ulnar variance. If the head of the ulnar is more distal to the distal radial articular surface, you have a positive ulnar variance. But here with this patient, we can see that the head of the ulnar side of the process, is more proximal to the distal radial articular surface, indicating that there's negative ulnar variance. And these patients with negative ulnar variance have a much higher risk of Kienböck's. So what is it? It's avascular necrosis, Kienböck's disease. Where? It's the lunate. How? So remember, with avascular necrosis, the classic appearance is sclerosis, flattening and fragmentation. Many patients are left with a residual physeal scar after their physis have closed. It's important to familiarise yourself with this appearance because it can be mistaken for an impacted fracture. So this sclerotic line that you see here that follows the classic location for a physis is normal. So it's really important that you familiarise yourself with this appearance.